Good evening everyone. Today we are going to discuss about hyperbilirubinemia. So what is hyperbilirubinemia? It is a condition where the bilirubin level is going to exceed the normal and the normal bilirubin level is going to range between 0.3 to 1 milligram per deciliter. If the level is going to exceed this 1 milligram per deciliter, we call it as hyperbilirubinemia. Let us say the level is going to exceed 2 milligram per deciliter, then the excess bilirubin seeps into the surrounding tissue and this becomes clinically evident as jaundice, which we also call it as icterus. So let us see how this bilirubin is produced in our body, or we can talk about the bilirubin metabolism. Normally, as the hemoglobin undergoes destruction, bilirubin is produced as the end product. Okay, and since it is a metabolic waste, out of the 300 milligram of bilirubin which is produced, all of them, almost all of them are excreted. And this excretion mainly takes place through bile. So what is bile? So this is a substance which is produced by the liver and it is stored in the gallbladder. And from the gallbladder, it is secreted into the duodenum in response to the digested chyme reaching the intestine. So in this picture, you can see the chyme is reaching into the duodenum. So this is going to cause the production of cholecystokinin, which causes the gallbladder to contract. And this causes release of stored bile into the intestine. And out of all the constituents of bile, this bilirubin is going to contribute only a tiny portion, remaining being majorly contributed by water and bile salts. Examples of bile salts are sodium taurocholate and sodium glycocholate, and remaining being contributed by phospholipids like lecithin and cholesterol. Now let us look into the bilirubin production and metabolism. Okay. So let us consider a senescent RBC. A senescent RBC is nothing but old RBC which has completed the lifespan of 120 days. And once this senescent RBC enters the reticuloendothelial system, they are engulfed by the macrophages there. So this is a pictorial representation of an RBC being engulfed by the macrophage. In the macrophage, the engulfed RBCs are broken down by the lysosomal enzymes. So let us see a marker. So here you can see the engulfed RBC is broken down by the help of lysosomal enzymes, and the hemoglobin in the RBC are thus broken down into heme component and the globin component, releasing iron in the process. The heme thus released is converted into biliverdin by the help of the enzyme heme oxygenase. The produced biliverdin is green in color. The biliverdin is further reduced into bilirubin by the help of the enzyme biliverdin reductase by a process called reduction. The bilirubin thus produced is yellowish in color. This bilirubin needs to be transported to the liver for further processing, but being water insoluble, it needs a carrier protein for its transportation in the blood, and this is being done by albumin. The albumin-bilirubin complex is carried via blood and it reaches the sinusoidal surface of the liver. In the liver, the bilirubin undergoes a process called as conjugation by which it becomes water soluble. The enzyme responsible is uridine glucuronide transferase. This adds the glucuronic acid molecules to bilirubin, forming mainly bilirubin diglucuronide, and 20% of them forms bilirubin monoglucuronide as well. This results in more water-soluble forms of bilirubin. Conjugated bilirubin thus formed is excreted through the bile, and the transport protein involved is called as MRP2 or multidrug resistance associated protein, and it helps in the transportation of bilirubin across the biliary canaliculus. Another transport protein called as OATP1B1 is also involved in transportation of bilirubin in the intrahepatic circulation. The clinical significance of this is The mutation of these two transport proteins are seen in some of the congenital direct hyperbilirubinemia like Dubin-Johnson syndrome and Rota syndrome. Now, through the bile, the conjugated bilirubin reaches the intestine. In the distal small intestine, two things happen due to the presence of bacterial flora in the gut. The conjugated bilirubin is unconjugated by the intestinal bacteria by the help of the enzyme beta-glucuronidase. The next one is the unconjugated bilirubin then undergoes reduction and forms urobilinogen. The urobilinogen thus produces excreted as stercobilinogen through feces, and this is how 80 to 90% of the bilirubin is excreted. And 10 to 20% of them enters the enterohepatic circulation and it is reabsorbed by the liver. A small portion in the enterohepatic circulation escapes the liver uptake and reaches the kidney to be excreted as urobilinogen. Both urobilinogen and stercobilinogen are colorless substances. When they are exposed to the atmospheric air, they are oxidized and they produce stercobilin and urobilin. And these are responsible for the stool color and urine color. So what is the clinical significance of this? In case a person is having obstructive jaundice, the water-soluble bilirubin does not reach the intestine because of the obstruction. So there is going to be no urobilinogen production in the gut. As a result, the stool is going to be pale in color and there is going to be no urobilinogen in the urine. So this is some of the clinical findings in obstructive jaundice: pale stools and absent urobilinogen from urine. So this is the schematic view where the RBCs, when they are old, they are going to enter the reticuloendothelial system. In the reticuloendothelial system, they are going to be engulfed by the macrophages there. This is going to release the hemoglobin, and the hemoglobin thus released is broken down into globin part and a heme part. The globin is going to reach the amino acid pool. Heme is going to release iron, which is going to be utilized for hematopoiesis. And the bilirubin thus produced is going to be excreted through the bile. So this is the whole picture of heme metabolism, how bilirubin is produced and how they are excreted. So let us see first the reticuloendothelial system is involved, how bilirubin is produced and how they are bound with albumin and transported to the liver. In the liver, they are conjugated and made water soluble and they are secreted into the intestine. The conjugated bilirubin here is deconjugated and it is also reduced and converted to urobilinogen, where they are further converted into stercobilinogen and excreted in the stools. 10 to 20% enters enterohepatic circulation. Some of them escapes and filtered through the kidneys and they are excreted as urobilinogen. So this is how bilirubin is excreted. Thank you. That's all for today. And today we discussed about bilirubin metabolism and what is hyperbilirubinemia. Next we will discuss about the types of jaundice in the upcoming sessions.